Welcome to the newly updated ANNA CKD modules that address nursing care of the patient with CKD in any setting. I am Leslie Dinwiddie, project leader for these modules. Today it is my privilege to introduce our author and presenter of the third module, Chronic Kidney Disease, Stages 4 and 5, and Overview of Therapy Options. Dr. Jamie Brown is an associate professor in the College of Nursing at the University of Tennessee's Health Science Center in Memphis. And among her many roles in ANNA, she is currently serving as the National Secretary.
Good morning, everyone. Welcome to the series, Chronic Kidney Disease, Nursing Care of the Patient with CKD in Any Setting. I am your webinar host. I am Dr. Jamie Brown. So, welcome to Module 3, Chronic Kidney Disease, Stages 4 and 5. So this module here, it is basically designed to help all healthcare professionals who care for a patient with chronic kidney disease, also known as CKD, and who also want to know more about late-stage kidney disease and the treatment options for kidney failure. So this set of modules, once again, chronic kidney disease, nursing care of the patient with CKD in any setting, it is dedicated to the memory of Ms. Sally Burroughs Hudson, a past president of ANNA and a fierce proponent of continuing education for all nurses. So thank you, Ms. Sally Burroughs Hudson, regarding these modules in the continuing education. So as you can see, this is the third module in the CKD What Every Nurse Should Know series created by the American Nephrology Nurses Association and should be viewed in conjunction with Module 1. Also, the nephrology nurses who have created these modules have done so believing that your understanding of our shared patients and their therapies will enhance our shared care of them and communication between us. So as you go through the module, you will see terms that are highlighted by an asterisk. So this asterisk basically indicates that that term is going to be defined in the downloadable glossary. So the patient with advanced kidney disease is dealing with a complex disease with many debilitating symptoms and having to make difficult decisions in the heights of surviving kidney failure. So therefore, this module will describe the patient with impending kidney failure. So at the end of this module, you'll be able to identify the patient with advanced chronic kidney disease, also known as CKD, discuss the treatment of patients in stage 4, describe patient education and preparation for kidney failure, and then also give an overview of treatment options for kidney failure. And then lastly, define kidney failure and treatment for stage 5. So let's begin with a quick review of normal kidney function. So we know that the kidney is going to perform many functions, but it definitely removes waste and extra fluid. Other functions of the kidney going to be included that the kidneys regulate body fluid volume through osmolality. They also excrete metabolic waste from the body, such as urea, creatinine, nitrogen, uric acid, and certain drugs and toxins. The kidneys also regulate the acid-base balance of body fluids through hydrogen ion excretion and bicarbonate reabsorption. They also regulate the balance of electrolytes, definitely including sodium and potassium. They also regulate blood pressure through the renin-angiotensin-aldosterone system. The kidneys are also responsible for 90% of the body's erythropoietin, which basically this here is going to stimulate the bone marrow production of red blood cells and other hormones such as prostaglandins and growth hormones. Also, the kidneys contribute to metabolic bone health by converting basically vitamin D to its active form. And then lastly, the kidneys are also a source of glucogenesis. So looking back in Module 1, we define CKD as abnormalities of kidney structure or function. that's going to be present for greater than 3 months with health implications. So CKD is going to be classified based on cause, glomerular filtration rate, also known as GFR category, and also albuminuria category. So most kidney diseases, they do not have symptoms until later and are basically detected only when they are severe, chronic, and advanced. CKD is basically, as we know, is going to be irreversible. And treatment is going to be aimed at slowing the progression of kidney failure. So what happens, as you might think about regarding CKD, so basically going to be progressing to the stages that we call advanced. So looking at the transition from the early stages to advanced CKD is going to be akin to the disease tipping point. So base is going to be a point of no return to normal kidney health, and the time when the emphasis of our care is going to be moved from treatment complications, palliating symptoms, and usually preparing the patient for kidney replacement therapy. So this advanced progression and the rate of decline of CKD is basically going to be directly linked to the loss of functioning of the patient glomerula, regardless of the cause of the patient's kidney disease. Also, we know that the kidneys now can no longer sustain homeostasis due to basically progressive glomerular sclerosis, which is basically going to reduce the overall number of the patient's functioning nephrons. Also looking at the kidney. So basically say even the structural and functional hypertrophy of those surviving nephrons are going to occur as the still functioning nephrons attempt to compensate for the loss of this function. Also, hyperfiltration is going to be increasing glomerular capillary pressure and temporarily going to be improving filtration. Also, this compensation mechanism, it's going to be explaining why there is going to be a significant loss in nephrons before symptoms of kidney disease are going to be evident. However, so basically these changes that we see, they're going to be predisposing the remaining working nephrons to sclerosis and ultimate failure. The failure rate is going to be evaluated by monitoring the patient's changes in their GFR and the amount of urine, or amount of protein in the patient's urine. So looking at clinical practice guidelines. So these are going to be the things going to be giving us very cohesive and comprehensive markers and direction in the identification, the evaluation, monitoring, and treatment of patients progressively through severely decreased kidney function. So begun in 2002 by the National Kidney Foundation, these CKD guidelines have been updated and revised for international use as the Kidney Disease Improvement Global Outcomes, basically known as KDIGO, 2012 Clinical Practice Guidelines for the Evaluation and Management of Chronic Kidney Disease. So basically details of this update can be found in the 2013 Kidney International Supplements and on the internet at www.kdigo.org. Okay, so this chart here is going to basically illustrate, as you can see, the KDIGO staging that considers both GFR and also albuminuria, utilizing the GFR categories developed by the National Kidney Foundation in 2002. So the KDIGO staging introduced in 2012 and updated in 2024 will be the basis for subsequent discussions of the progression and the symptomology of CKD in this module and other future modules. So this slide also, as you can see, is going to be giving us a visual representation of the KDIGO CGA staging. So this visual representation with the color changes emphasizes that the presence of protein is in the urine. It's going to be insufficient quantities, changes regarding the level of the risk of progression and severity of the prognosis for CKD. So basically, even in regarding this module, so it's going to be focusing on stages 4 and 5, when the advanced degree of disease and if necessary treatment for the best patient prognosis hinge on the patient's referral to the interdisciplinary nephrology team. So in looking at the clinical consequences of advanced CKD, so when we assess patients, we first look at the clinical consequences of the stage that that patient is in at that time. So most significant is going to be the CKD patient's increased cardiovascular disease risk, also known as CVD. Also looking at literature from, let's say, the past 20 years, it's going to show a powerful synergy between CKD and also CVD, with nearly 50% of patients in CKD stage 4 dying from cardiac events. We also know that the prevalence of coronary heart disease in stage 5 is about 40%. Also looking at, let's say, regarding hypertension, which is basically going to be defined as a systolic BP at or above 140 of millimeters of mercury, or a diastolic blood pressure at or above 90 millimeters of mercury. It's going to be identified in 50 to 75% of patients with CKD stages 3 to 5, and 25% of all patients receiving dialysis. Also, dyslipidemia is going to occur when the patient develops a disturbance of lipoprotein metabolism. So this is basically evidenced by depressed high-density lipoprotein, also known as your HDL, and elevated triglycerides. Looking at hyperphosphatemia, elevated calcium and phosphorus products, and hyperparathyroidism, they have also been associated with cardiovascular disease risk and mortality in advanced CKD, particularly in the form of vascular calcification. In addition, uremia is going to be believed to confer non-traditional cardiovascular disease risk through a pro-inflammatory state and a dysregulation of calcification inhibitors and inducers. So cardiovascular disease mortality is going to be 10 to 30 times greater in this population regarding CKD than in the general population. And it's also believed to be a result of CKD mineral bone disease. So, as far as we know, basically here, as kidney function decline is also progressive deterioration in mineral homeostasis. So CKD, mineral bone disease, also known as MBD, is going to be a systemic disorder that occurs when the kidneys lose their ability to remove excess phosphorus. MBD is going to manifest in one or a combination of calcium, phosphorus, parathyroid hormone, also known as your PTH, or vitamin D metabolism, and abnormalities in bone turnover, mineralization volume, linear growth, or strength. It can also be a major contributor to vascular or other soft tissue calcification, resulting in your patient having significant morbidity and mortality. Well, you might ask, how does this come about? Well, in normal physiology, we're going to be seeing that the parathyroid gland is going to be monitoring phosphorus and calcium levels in the patient's blood. So as serum phosphorus level increases, the parathyroid gland is going to respond by increasing the excretion of the parathyroid hormone, which would typically going to be causing the kidney to secrete more phosphorus and absorb more calcium. However, though, in CKD, the kidneys are going to be unable to do either one of these. A secondary result of an elevated parathyroid hormone is going to be the movement regarding calcium from the bone into the patient's bloodstream, which is going to basically be causing the patient to have bone abnormalities in an attempt to maintain adequate serum ratios. So typically, As CKD progresses, parathyroid hormone levels are going to be rising along with serum phosphorus. This is going to be commonly called hyperphosphatemia. So the other significant clinical consequences of advanced CKD, which also has cardiovascular ramifications in the form of left ventricular hypertrophy, is going to be anemia of CKD. So this is going to basically start as early as stage 3A. And it's going to be normocytic, normochronic anemia caused by a deficiency of erythropoietin, which basically 90% of which is going to be produced by those kidneys that are healthy kidneys. Added to the diseased kidneys, the inability to reduce erythropoietin, this anemia is often related to reduced availability of iron. So it's going to be exacerbated by the chronic inflammation of uremia, which we know is going to be shortening the lifespan of those red blood cells, also known as RBCs. So we cannot assume that signs and symptoms of anemia are produced by CKD alone. So therefore, we must continually evaluate for any other potential underlying causes of anemia, such as, for example, vitamin deficiencies, bleeding, infection, and accompanying inflammation. So, considering the primary functions of the kidney, it should come as no surprise that as kidney function declines, so does the ability to regulate both fluid and electrolytes. So we know that fluid overload is going to result from excessive fluid accumulation, which is going to alter urinary concentration, and the adequate removal of many substances is going to be contributing to heart failure. So even let's say when the patient GFR reaches about 20 milliliters per minute, there's going to be a decrease in sodium and free water elimination, resulting in extracellular volume expansion, causing signs of basically fluid overload, which is going to be most notable regarding seeing it as peripheral edema. Relating this, say, to electrolytes. So these abnormalities are going to be resulting in metabolic acidosis caused by the failure of hydrogen ion excretion. They may be compounded by bicarbonate loss, particularly in interstitial kidney disease, as well as sodium and water retention. Hyperkalemia is basically going to be resulting from a decrease in kidney excretion of potassium. Also may be related to an increased ingestion of potassium in the diet, cellular injury, or metabolic acidosis. So hyperkalemia is going to be one of the most immediately dangerous signs of worsened kidney function. Elevation in serum potassium is going to basically lead to generalized muscle weakness and lethal cardiac arrhythmias. So signs on an EKG may include those tall peaked T waves and the widening of the patient's PR and the QRS complexes on the EKG. If left untreated now, hyperkalemia can progress to asystole and also death occurring. So our patient health is going to be further challenged by the malnutrition that can occur in CKD stages 4 and 5, and it's going to be associated with an increased risk of death. Causes of malnutrition may include anorexia, nausea and vomiting, metabolic acidosis, insulin resistance, inflammation, and also urine protein loss, which are going to all be classic signs of uremia and are going to be indicative of impending kidney failure. So, referral to a dietitian for assessment, treatment, and education is going to be essential during this time. In the endocrine system, we also know we must pay close attention to altered insulin metabolism, specifically reducing insulin clearance. So this is going to be creating a setting where hypoglycemia can quickly occur. So remember also that diabetes is going to be our leading cause of kidney disease, and it's going to be the largest comorbidity in the incident and the prevalence regarding kidney failure populations, with about 39% of all patients on dialysis having diabetes. We also have to be considerate of that changes in the patient's sexual and reproductive hormones are going to be quality of life issues for many patients who have CKD. Also, speaking regarding that, so that reduced testosterone and increased estrogen and luteinizing hormone are going to contribute to impotence and reduce libido in males. Also, reduced cyclic luteinizing hormone levels may result in amenorrhea and anovulation in females, making infertility common and pregnancy rare. Hypothyroidism. It can also result from a reduction in the conversion of T4 to also T3, which is going to be the most active endocrine component for the patient's thyroid health. So overall, a reduction of growth hormone levels is going to be seen in young children, secondary to increased levels of substances that are going to be reducing the synthesis of this important hormone. So with the immune system, we know that CKD is going to create a state of chronic immunosuppression, which is going to be defects of both cellular and humoral immunity. T cell responses to antigens are going to be deficient, partially because of the patient's impaired antigen presentation by monocytes. So those psychological manifestations are going to be including anxiety and depression, along with the patient having slowing of the mental processes. So significant cognitive decline has been well documented in advanced CKD. It's going to also be affecting the patient's both quality and the quantity of their life. So speaking once again about the KDIGO guidelines, so they specifically recommend referral to a specialist kidney care services for people with CKD who have any of the following findings, such as acute kidney injury, also known as AKI, which is going to be present with an abrupt, sustained fall in GFR, a constant finding of significant albuminuria. Also, regarding that, basically having an albumin to creatinine ratio greater than 300 milligrams per gram, urinary red blood cell counts, red blood cells in the urine, hypertension refractory to treatment with 4 or more antihypertensive agents, abnormalities in serum potassium, nephrolithiasis, and hereditary kidney disease. So people basically with either an abrupt fall in GFR or those with a progressive decline are going to be needed that ongoing evaluation and treatment for reversible causes of progression. Also, we know that early identification and management of patients before reaching stage 4 of CKD are going to be essential to prevent or treat complications of CKD. So this is going to be allowing enough time to educate the patient and their families about the treatment options for kidney failure and optimally preparing them for kidney replacement therapy, also known as KRT, if that is that patient's choice or family member's choice. So KDIGO guidelines also recommend immediate referral to the nephrology specialist for all people with a 10 to 20% or higher risk of kidney failure within 1 year. Also, to appreciate the benefits of timely referral, the following few slides in this presentation will give an overview of the clinical consequences of advanced CKD and the less than positive outcomes that may occur if patients basically are, if they are not referred and treated. So with the immune system, hold on, don't got a little ahead of my back. Okay, there you go. So basically, as communicated, patient with advanced CKD going to have a complicated trajectory and a complex management challenge. So still, all of these clinical consequences are going to be immediately treatable, which is going to be the major benefit of that early referral to the nephrology interdisciplinary team. So the 10 to 20% of greater risk of kidney failure progressing to the need for kidney replacement therapy within 1 year, the person with advanced CKD should be referred. Most importantly, it's going to be allowing the nephrology interdisciplinary team to assist the patient's health-related knowledge and treatment expectations and understand their preconceived lifespan. So this is going to be vital because we know that on average, it's going to take a year to provide the education that's going to be needed to complete those referrals indicated for the initiation of dialysis or transplantation if kidney replacement therapy is their choice. Also, and during that year with treatment, the patient will have the benefit of integrated management of cardiovascular disease, as well as the management of anemia and mineral bone disease, better nutritional status, increased awareness of all treatment options, and the placement of a peritoneal dialysis catheter or vascular access if they choose to start dialysis or the workup, including the choice of a living donor for a preemptive transplant. Also, with that comes psychological support and the provision of palliative care when that is appropriate. So, other benefits of an early referral are going to be a reduced need for urgent dialysis, reduced length of hospital stay, better psychosocial adjustments, and improved mortality. So while these slides have mentioned the benefits of early referral that patients experience in both quantity and quality of life, possibly the most significant benefit to the quality of life is going to be the prevention of uremia. So you might be asking, what is uremia? Well, it means that urea or urine is in the blood and it's going to affect every system and cell of the body. So basically, this clinical syndrome is going to feature fluid and electrolyte abnormalities, hormonal imbalances, and metabolic abnormalities. So uremia is going to worsen as kidney function deteriorates. And the metabolic waste product is going to be building to toxic levels in the blood and also the tissues. So also we know that uremia is going to be the syndrome that finally gets the uninsured or the underinsured CKD patient to the emergency department or the doctor's office. So common symptoms are going to be included nausea and vomiting, loss of appetite, a metallic taste in the patient's mouth, fatigue, muscle cramps and weakness, swelling, itching, alteration in mental status, such as confusion and a reduced attention span, also shortness of breath. So physical examination of the patient with uremia is going to reveal the patient having, let's say, for example, pale skin, which is going to be related to the anemia of CKD, a yellowish hue due to accumulated urochromes found in the patient's skin that would normally be excreted in the patient's urine, and dryness on the skin due to toxins within the patient's skin, a decreased function of the patient's sweat glands to flush them out, and calcium phosphate deposition. So this calcium phosphate salts are going to be crystallizing on the patient's skin, a sign that we often hear called uremic frost. It's going to be causing pruritus and basically the uremia. So the itching that we're going to be seeing and the scratching is going to be leading to ecchymosis and purpura, which are going to be exacerbated by alterations in coagulation factors. So edema is also going to be secondary to fluid retention. Pulmonary dysfunction is going to be characterized by the patient being short of breath and also having rales. Also, we know the increased fluid overload will often result in fluid accumulation in the patient's lungs. Anemia also going to make the patient with uremia pretty much hungry for oxygen, resulting in the patient, let's say, being fatigued and having increased stress on the already stressed cardiovascular system. Also, we know that hypertension and heart failure are often going to be coexisting, basically complicating the picture. And as you can see, we're going to expect to see the patient have left ventricular hypertrophy. In the extremely uremic patient, you may hear a pericardial friction rub or evidence of a pericardial effusion with or without tamponade, which is going to be reflecting uremic pericarditis. In addition to nausea and vomiting, there may be also spontaneous or chronic GI bleeding due to that irritation of the serous membranes and anticoagulation factors that are going on in the patient's body. So the patient, once again, may have that uremic factor, which is going to be basically an ammonia-like or a urine-like odor to the breath, basically due to the accumulation of that urea in the patient's blood. In extreme uremia, we're going to be seeing, once again, neurologic symptoms such as carpal tunnel and other nerve entrapment syndromes. Foot or wrist drop, that neuropathic pain may be evidence of uremic motor neuropathy, along with the patient, say, having tremors. Multifocal myoclonus, restless leg syndrome, or seizures, all due to that uremic encephalopathy. Also, spontaneous subdural hematomas may occur due to the patient, let's say, having irritation to the serous membranes, and also, once again, that ultracoagulation factors. So the interdisciplinary team, once again, they must work together to manage the many facets of treatment, some listed on this side, also necessary regarding for advanced CKD. In addition, that therapeutic lifestyle modifications such as smoking cessation, weight loss, diet and exercise, these things here, they must be addressed, along with preventive care such as appropriate immunizations. The nephrologist, the nurse practitioner, and or the PA also going to be overseeing the treatment of complications such as anemia and mineral bone disease, while still ensuring that treatment for the referral or other underlying or comorbid medical conditions such as diabetes and cardiovascular disease are still part of the ongoing evaluation of medications. Also, we know that dietary modification is going to be important, basically to adapt to the complications of that metabolic breakdown. It's going to require basically a nutritional consultation regarding by the patient having nutritional counseling with the dietitian. Also, kidney replacement modality education about future treatment options is going to be important, especially with clear information about the surgical aspects of creating a dialysis access is going to be a high priority in patient preparation. Also, kidney care coordinators, typically the nurses, are going to be responsible, though, for most of the patient's education. Also, know that many patients and their families, especially those who are uninsured or underinsured or are having difficulty with employment expectations, will have serious financial concerns regarding the cost of those current and future treatments. So, with that in mind, kidney disease social workers are going to have the expertise to manage these concerns, as well as psychological issues such as depression and also anxiety. The interdisciplinary team must also manage clinical dilemmas, which are going to arise, let's say, when the patient is not legally competent. So overall, all care, it must be patient-centered. So while the care of every patient is an interdisciplinary responsibility, we know that the nurse is going to be with the patient more than any other team member. We also know that our process of care is not limited to specific medical orders for a specific diagnosis. A priority in our assessment is going to be understanding each patient's preconceived knowledge of their health status and their life plan. Patient education is going to be tailored to that plan. It's going to be critical to the patient-centered care. ANNA's publication of the Nephrology Nursing Scope and Standards of Practice, based on the 9th edition, it's going to have a wealth of information for all nurses about the education that these patients are going to be needing in all aspects of their care, especially when it comes to self-management across all categories of CKD. So the next section of this module will highlight patient education, focus on the management of potential complications, and its selection of options, including kidney replacement therapies. So, in keeping with the nursing process, we must assess that the patient and the family already know and their ability to learn. So, the cognitive implications or complications of advanced kidney disease and the urgency of treatment will also impact the patient's learning process. So this slide here basically lists some topics we're going to cover when patients with CKD are newly referred. Of course, these topics are going to be tailored to the patient's particular risk factors and their medical prescription. So patients who understand their prescribed treatment are more likely to adhere to it. So we know that the next few slides that I'm going to be highlighting, especially regarding the interdisciplinary team's treatment goal for the clinical consequences of advanced CKD. So the overall goal of medical treatment is to manage the complications of advanced CKD and to treat the underlying disease and other comorbidities. Now, the care becomes more focused on maintaining homeostasis while assuring patient comfort. So speaking of, let's say, regarding blood pressure management, it's going to become more complicated as the kidneys lose their ability to remove unneeded fluid. In addition to that, we're going to see the reduction of modifiable health risks through dietary changes, smoking cessation, exercise and weight loss. Medications are going to need to be continuing to be adjusted. Also, we know as kidney function declines, the effectiveness of diuretics will also decrease, but they will continue to be used to basically reduce circulating blood volume. There's also going to be ongoing evaluation and treatment for lipid abnormalities going to be continued to basically aid in the reduction of cardiovascular risks. Also, concerning mineral bone disease, we're going to have efforts to minimize the absorption of phosphorus, including reducing the dietary intake of foods that's going to be high in phosphorus, and the addition of phosphate binders. So, phosphate binders, they must be taken with meals, basically to bind phosphorus as it enters the patient's digestive tract. Also, prevention of hyperparathyroidism is also going to be further managed by administering calcium mimetic therapy. Also, let's take a closer look at each of these. So, looking at, let's say, hypertension therapy, we're going to keep in mind that all drugs need to be dosed according to the patient reduced kidney function guidelines. So, chapter 3 of the KDIGO guidelines is going to focus on management CKD progression and also its complications. So remember that hypertension is both a cause and a complication of CKD. So blood pressure control is probably going to be the most important strategy to delaying disease progression. Also, we know that blood pressure goals are going to be dependent on the degree of albumin in the patient's urine. regardless of the patient's status of having diabetes. So basically, the goal is going to be less than 140/90 for those who have albuminuria, under 30 milligrams in 24 hours, and less than 130/80 for those who have albumin in the urine, greater than 300 milligrams in 24 hours. An ARB or an ACE inhibitor, so they also may be used for patients with diabetes who have albumin in their urine, of 30 to 300 milligrams in 24 hours, while an ARB or ACE may be used for patients both with and without diabetes with albumin in their urine greater than 300 milligrams in 24 hours. So basically, these antihypertensive medications are going to be crucial to delaying the progression of kidney failure through the reduction of albuminuria. Also, depend on the patient. Other antihypertensive medications may be required for successful BP reduction, such as beta blockers, calcium channel blockers, and also diuretics. So, looking at dyslipidemia. So, the majority of CVD is going to be caused by risk factors that can be controlled, treated, or modified, such as high blood pressure and high cholesterol. So, raised serum cholesterol is going to increase the risk of heart disease and also a stroke. So, 1/3 of ischemic heart disease is going to be attributable to high cholesterol. So, overweight and obesity, high dietary intakes of saturated fat, trans fat, and sodium, along with decreased consumption of fruits, vegetables, and fish, are linked to cardiovascular risk. Tobacco use is going to also be responsible for those nearly 10% of all patients regarding cardiovascular deaths. And insufficient physical activity is going to be the fourth leading risk factor for mortality in the general population. So, as I mentioned earlier, in discussing the clinical consequences of advanced CKD, a non-traditional cardiac risk factor is going to be calcification of the patient's blood vessels and heart tissue. So the suspected cause of these is going to be that vascular calcification is going to be CKD, metabolic bone disease. So the guidelines recommend measuring serum levels of calcium, phosphorus, parathyroid hormone, alkaline phosphatase activity, and vitamin D at least once in adults with a GFR less than or equal to 45 to determine basically the patient's baseline values to prevent that metabolic bone disease. Now, in stage 4, however, serum calcium and phosphorus is going to should be measured every 3 to 6 months, and PTH should be measured every 6 to 12 months. In stage 5, the frequency of these measurements is going to be increased regarding serum calcium and phosphorus to every 1 to 3 months, and parathyroid hormone to every 3 to 6 months. So looking back, remember also that metabolic bone disease is going to be initially caused by hyperphosphatemia due to the failing kidneys and ability to excrete excess dietary phosphate. Okay, also know the treatment is going to focus on minimizing absorption. It's going to be included in reducing dietary intake of those high phosphorus foods and adding phosphate binders. So basically, these phosphate binders, they're going to be, as once again, taken with meals because, hey, we're trying to bind that phosphorus into the patient's digestive tract. So some common phosphate bonds are going to be calcium carbonate, calcium acetate, so acevelamide, hydrochloride, and others. Prevention of hyperparathyroidism that's going to be resulting from that chronic hyperphosphatemia is going to be further managed by that calcium mimetic therapy. Guidelines further advise maintaining serum phosphate concentrations in the normal range because basically higher concentrations are going to be associated with an increase in mortality. Once again, also we know that serum phosphate, calcium, and parathyroid hormone concentrations are also interrelated in patients with CKD. Therefore, it's going to be advised that people with levels of intact parathyroid hormone above the upper normal limit of the say are first evaluated for hyperphosphatemia, hypocalcemia, and vitamin D deficiency. So, regarding anemia management, so as the patient's kidney function declining, so does the availability of erythropoietin. So therefore, management going to be including IV iron as the initial therapy and also erythropoietin stimulating agents, also known as those ESAs, to supply basically new RBCs. Speaking of, let's say, ESAs, they should not be used to intentionally increase the patient's hemoglobin concentration above 11.5. Also, those erythro-stimulating agents therapy is not recommended in those with active malignancy or a recent history of malignancy due to the FDA's black box alert. Also, we know that ESA therapy has very defined guidelines to follow and when to start. Therefore, the patient needs to have a hemoglobin less than 10 to start and must be maintained between 10 and 11 for patients with CKD due to the potential of those life-threatening cardiovascular events when the hemoglobin level becomes greater than 13. Also, when the patient starts taking ESAs therapy, the patient's blood pressure should also be monitored because here it can become elevated with the correction of the patient's hemoglobin. So the benefits regarding, let's say, managing anemia are going to be the reduction of left ventricular hypertrophy and a reduced symptoms of fatigue and shortness of breath. Chronic illness and inflammatory states also alter, as we know, iron utilization and going to shorten that red blood cell lifespan. Also, keeping in mind that avoiding transfusions is also going to be very important. We also want to keep in mind that hemoglobin goal is typically 11, but treatment primarily manages symptoms and increases quality of life. CKD, once again, is going to impact the patient's ability to balance salt and water. So here we're going to be seeing alteration in fluid or volume balance are going to be usually present as hypervolemia. Hypervolemia, or also we know as fluid volume overload, is going to often be determined by the amount of fluid retained on the body. So basically, here's when we have water intake is going to be exceeding output, usually basically in sodium retention. So as a patient, let's say kidney function declines or reduces, the body's ability to remove excess fluid is going to be a problem. So here we're going to be having less residual kidney function the patient has. The more important is going to be coming to managing the patient's fluid intake, which is going to be necessary to minimize those cardiac and pulmonary complications. So fluid volume, it does not usually become an issue in the early stages of CKD, unless it's going to be accompanied by those cardiovascular diseases. Also, we know that edema can occur in the lower extremities, the patient's hands, abdomen, back, or face. Yet, if it's not treated, edema can cause a significant increase in blood pressure, and if untreated, it can cause shortness of breath and heart failure. Also, low albumin levels and anemia are also contributing causes of edema in patients who have CKD. So management is going to be focused on sodium restriction and fluid restriction. Loop diuretics such as furosemide are definitely going to be usually effective too regarding volume control in patients who have CKD. They're going to be having an added benefit regarding assisting with that potassium excretion. Also, patients may be asked to record their weight and also compare their findings or their readings to evaluate, let's say, weight gain or weight loss, or the effectiveness, let's say, regarding their patient's diuretic therapy. Also, as the kidney function decline, we're going to be seeing the ability to regulate electrolytes going to be definitely impacted. Therefore, it's going to become extremely important to evaluate those critical lab values regularly. So potassium is going to be shifted from the from the intracellular to the extracellular space with evolving acidosis, basically resulting in hyperkalemia. So this is going to be one of the electrolytes that must be carefully monitored. So as part of the assessment of the elevated potassium is going on, we need to be important to verify the patient's serum potassium level by repeating the lab, just in case the specimen, let's say, maybe have hemolysis by the lab, because here it may be potassium level, here may be phosphorally elevated. Also, EKG changes can and they also do occur. So EKG changes with high potassium levels may include, once again, those tall PT waves, a prolonged PR interval, or a widening of the QRS interval. As discussed earlier, this module and module 2, an elevated potassium level can be lethal. So changes in potassium level can herald worsening kidney failure. Dietary restriction of potassium-containing foods and medications definitely would need to be instituted. While we once, let's say, relied upon Xylate, there are new medications out on the market, such as Leukemia, are now used to treat hyperkalemia. And basically, they are more effective and better tolerated than Xylate. Additionally, it's going to be essential to carefully monitor, once again, the patient's serum potassium levels after the initiation or increase in the ACE or the patient who takes our medications. Emergency treatment for hyperkalemia, it may include IV infusions of glucose, insulin, calcium, and phosphorus-binding medications, and or emergency dialysis. So the situation here needs to be addressed immediately. Without treatment, the problem will continue to worsen and the patient will die. Another electrolyte that's going to be regulated in part by the kidney is going to be sodium bicarbonate. So metabolic acidosis is going to be basically our pH acid-base problem or disorder. It's going to be characterized by a fall in the serum bicarb concentration in CKD. Metabolic acidosis occurs when the bicarb is lost from the body via the kidneys, and the kidneys fail to regenerate bicarbonate through adequate acid excretion. So basically, we have low pH, low bicarb level. A low serum CO2 level diagnosis, metabolic acidosis. Sodium bicarbonate also going to be the treatment for metabolic acidosis. So patients should be informed of the importance basically of taking the drug when and as prescribed, so not to interfere with the action of other medications that the patient may be taking. So sodium bicarb levels, they should be maintained above 20 milliequivalents per liter, and sodium bicarbonate dosage should be adjusted accordingly. The treatment of metabolic acidosis is going to decrease protein tissue breakdown and improve bone mineralization. Untreated, however, metabolic acidosis is going to become a serious complication that may lead to increased protein degradation, contributing to the patient having nutritional compromise. So, to avoid malnutrition, it's going to be typically recommended that the diet includes basically adequate protein intake of at least 1 to 2 grams per kilogram per day, more than 50% of which is going to be protein of the high biological value. Also, as we know, decreased protein is going to be linked to metabolic acidosis, muscle wasting, weakness, and reduced immune response. Caloric intake is going to be related to obesity, a significant change in body weight, and or diabetes. So the recommendation is going to be that it's going to be make sure that we be adequate to minimize catabolism. Also, food restriction is going to be definitely important because here it's going to be related to urine output and other insensible fluid losses. So the restriction regarding fluid is going to be typically between 500 to 1,000 milliliters per day, plus the amount of the patient's urine output. So as urine output declines, oral fluid intake needs to be reduced. So once the patient is on dialysis, fluid intake is going to be based on toleration of fluid removal during dialysis and overall cardiac stability. Now, most water-soluble vitamins, they're going to need to be replaced, especially say once dialysis begins. Fat-soluble vitamins, especially when it comes to vitamin D. It may be used to control, let's say, hyperparathyroidism. Also, restrictions on electrolytes and minerals like sodium is going to be 2 grams per day, potassium 1 to 2 grams per day, phosphorus 800 to 1,000 milligrams per day, and calcium less than 2 grams per day are going to be adjusted based on the patient's laboratory values. Also, with that, any herbal or other supplement, it must be carefully evaluated for the presence of substances restricted in patients who have kidney failure. So, just teaching patients and their families about the detail of their current therapy is not enough. They also need to understand that they're going to have a big picture of their plan of care. They need to know why and schedule follow-up monitoring with the nephrology interdisciplinary team and their PCP. They also need to be taught what they should self-monitor and communicate to the healthcare provider, the signs and symptoms that they may be seeing or expect to experience, the long-term goals, and what's going to happen when, let's say, the kidneys actually do fail. So this whole conversation, it may be a subject of great anxiety for some patients and others. In addition, individuals with advanced kidney disease, they may experience grief related to deteriorating health and having to consider starting kidney replacement therapy or dying of kidney failure sooner than their preconceived lifespan. So patient education is going to be definitely a priority because early choice of an appropriate kidney replacement therapy and the creation of a dialysis access is going to help prevent the need for urgent dialysis and patient hospitalization. So this hopefully is going to result in better patient outcomes and reduce financial costs. The interdisciplinary team not only educates the patient and the family about the therapy options, but also going to be advising them on the benefits and the challenges of each and which should be most suitable for the individual patient from both the physical and the psychosocial aspects. Now, for some patients, supportive management and palliative care, it may be an option for the patient and the family. Once again, treatment must always be patient-centered, meaning that it's going to be ultimately up to the patient and the family to choose how they want to live the rest of their life, given the limitations of their disease and the most appropriate treatment options. With this in mind, the following slides are going to basically be focusing on major treatment goal for the patient in stages 4 and 5, presenting the option for kidney replacement therapy, and a brief overview of the preparation for each form of therapy. So related to patient, let's say treatment goals. Transplantation will be the first modality listed here because it brings basically superior outcomes, for the suitable patient in terms of both quality and quantity of life. It's going to be especially important when it comes to considering transplantation. First, because those preemptive transplant not only confers these benefits, but also bypasses, let's say, the need for dialysis and its risks and its challenges. Self-care or self-managed dialysis, including peritoneal dialysis and home hemodialysis, is going to be discussed next because these home therapies are next in the hierarchy of benefits, let's say, when it comes to the patient regarding quality of life and survival. In addition, they will require considerably more preparation on the front end than assisted care in-center dialysis, where basically the emphasis is going to be on early placement of a dialysis access and monitoring, let's say, of the symptoms. So related, let's say, to incidence and prevalence of kidney replacement therapy, the figure on the left displays the number of patients with incident kidney failure who began kidney replacement therapy. Now, the figure on the right, it basically shows the distribution of the prevalent population, reflecting all the patients receiving kidney replacement therapy on the last day of the year. So it is going to be significant to note that transplantation prevalence has more than doubled in the past 20 years. So while we know that transplant has a superior outcome in terms of both survival and quality of life, patients need to understand basically that kidney transplantation also has risks. So most importantly, patients must know that transplantation is not a cure because they will have to take immunosuppressant medications for the life of their transplant, basically to prevent transplant rejection. They also must continue regular testing and follow-ups with their transplant team. The patient also must know they will live with a single functional kidney. So this basically means that they only have the kidney function of a person with two healthy kidneys. Even considering that, for most patients, transplantation is going to offer outcomes superior to hemodialysis or peritoneal dialysis. It's going to be improving quality and life. It's going to be less costly than dialysis. With the return of normal kidney function, it's going to be the potential for a longer, more normal, healthier life for those fortunate enough to receive a kidney. Yet, however, we know that patients need to know that the limiting factor for the option of transplantation is going to be those there are not enough basically deceased kidney donors to provide enough kidneys for those who are on a waiting list. So looking at the United Network for Organ Sharing, also called your UNOS, data between 2017 and 2023, there have been some 122,000 deceased donor kidney transplants and almost 43,000 living donor kidney transplants were performed in the United States during this time. As you can see, that volume is growing yearly. However, though, this tells us that donor numbers are insufficient to meet the demand. So this is going to reinforce that the donor approach process, particularly say with deceased donors, must be done in a very sensitive fashion and of course in accordance, let's say, with the law. Although we know that all of us and our loved ones are potential donors, living or deceased, still many healthcare workers and the general public are unaware of the vast disparity between the number of kidneys donated and the number of kidneys that are needed. Only 1 in 4 patients waiting for a kidney will receive a kidney. Looking at the next slide, it's going to be designed to help you further understand donor information. So among the 5 categories of kidney donors, the deceased donor category stands out as the largest. These are basically individuals who either by their wish or the consent of their family members have generously directed their organs for transplantation among their death. So this selfless act is going to benefit the patients on the waiting list, providing them with a new lease on life. Directed donation is a small subset of this category. Directed donation options basically is going to occur when a donor specifically selects the individual to whom he or she wants to give a kidney upon death. The remaining categories are all living donors. The most common is going to be your living related donation, which an organ will be donated from one family member to another, such as between a sibling or a parent to a child. Living unrelated donation is going to be donating an organ from one individual to another when the individuals, they are not blood related. So this is commonly between, let's say, spouses or let's say among friends. Non-directed kidney donation is going to be involving a living donor wishing to donate one of their kidneys anonymously to an unspecified recipient. So this situation also referred to as an altruistic donation. A living donor pair donation is going to involve two pairs of living kidney donors and transplant candidates who do not have matching blood types. So the two candidates here are trade donors, basically. So they each basically are a candidate going to receive a kidney from a donor with a compatible blood type. A preemptive basic kidney transplant is the transplantation of a healthy kidney before the patient's kidneys basically have failed. It's going to be transplantation prior to dialysis. KDIGO guidelines advise that living donor preemptive kidney transplantation should be considered in adults when the GFR is less than 20 and there is evidence of irreversible CKD. A nephrologist is going to be referring as the potential preemptive transplant candidate to the transplant team. Potential transplant recipients are going to be required to attend a transplant class to understand basically the transplant process, the risks, and the benefits of them having a transplant. The risks of the operation and the risks and side effects of immunosuppression are also going to be explained to the patient and also to their family. After the initial information session, the potential transplant candidate is going to undergo, let's say, various tests to determine basically if they are a good candidate for kidney transplantation. At the same time, the process of identifying a potential donor is going to begin during this time period. So, an informed consent for potential donors is also going to be obtained to undergo the necessary assessment. So the person here is going to be given consent. They must be competent. They must be willing to donate. They also must be free from coercion. So basically harassment, being threatened, those types of things. Also, they must be medically and socially suitable. They need to be fully informed of the risks and the benefits of donation and fully informed of those alternative treatments available to the recipient. Then potential donors, they must complete several tests to determine their physical suitability for organ donation. Okay, so testing of the potential donors will be designated to answer three main questions. So first, is a potential donor at a higher risk to undergo the actual surgical procedure than would be expected? Second, what's the donor's degree of risk or developing medical problems in the future as a result of having a single kidney? And then third, are there recipient issues such as risk of cancer or infectious disease, transmission via the donor organ, or factors that will lead to an unacceptable risk of early graft loss, such as a recurrent disease? Now, any affirmative answers to these questions may rule out a potential living donor because of the ethical standard of doing no harm. If the potential recipient does have transplant risk, a deceased donor kidney may be a better option for this patient. Okay, so testing of potential donors will be designated or to answer. I just said that. Sorry about that. So transplant centers, they have their own protocol for evaluation and category for candidacy. So in general, transplant candidates are going to be screened for the following conditions. So basically recent or metastatic malignancy, untreated or current infection, advanced cardiopulmonary disease, high risk for surgery, severe irreversible comorbidities, severe multi-organ dysfunction, psychiatric illness, which is going to be impairing consent and adherence, current recreational drug abuse, potential for recurrent kidney disease, primary oxalosis, and also recalcitrant treatment. So, speaking of immunosuppressant medicines, they're going to be very essential. So these drugs are basically going to be inducing graft tolerance and preventing early rejection. So successful transplantation is going to be dependent on absolute adherence to the immunosuppression regimen. Also, we know the patient's immune system is going to be recognizing that the transplanted kidney as non-self, and let's say as being foreign. And so we know that organ rejection will occur without adequate and continuous immune system suppression. Immunosuppressant drugs, they also must be taken for the life of the transplanted kidney. Patients also must take their immunosuppressants at the same time every day. And when the medications, let's say, are ordered twice daily, the dosages should be as close to 12 hours apart as possible. Yet, immunosuppressants, they are all going to cause side effects to some degree. So therefore, maintain adequate immunosuppression and avoiding infections or those other adverse effects from these medications will be a constant balance act. Therefore, monitoring and also patient education are going to be definitely key to effective management in regards to immunosuppression therapy. So this section of the module basically has presented an overview of the preparation and process for care for both the donor and the recipient of the kidney transplant. In summary, kidney transplantation will be the treatment of choice for patients with kidney failure. Kidney transplantation also allows the recipient to lead a much less restricted lifestyle and will provide a more cost-effective treatment method than long-term dialysis. In addition, it's going to be the superior kidney replacement therapy in terms of quality and quantity of life for the suitable patient. However, less than 1 in 4 patients wanting a kidney will get one because there aren't enough kidney donors. For stage 4 or early stage 5 CKD patients, a preemptive transplant is going to be your possible option if a suitable donor is identified. Living donor donation is going to be safe and has better outcomes for the recipient in the short term, but deceased donor kidneys also do very well. So by definition, all transplant patients have chronic kidney disease, and the transplant is not a cure because of the potential for rejection and the need for immunosuppression therapy. So please keep a note to see Module 5 for more detailed information on transplantation. So while transplant is going to be the kidney replacement therapy with the best outcomes, the majority of patients begin kidney replacement therapy on dialysis, primarily because that preemptive transplant is a complex, time-sensitive, and a donor-dependent option. So as you have seen, let's say from the previous data slides, the vast majority of incident kidney failure patients fall into the assisted hemodialysis realm because basically these patients here, they are unable to perform self-care dialysis in the form of peritoneal dialysis or home hemodialysis for a variety of reasons, including, for example, late referral, burden of illness, and the need for an urgent start. So the options model in the center of this slide basically illustrates the relationship between the modes of care and the setting for this care. So self-care dialysis on the left, whether it be peritoneal dialysis or hemodialysis, can be performed primarily by the patient in the setting of his choice, or their choice, I should say. While it is usually at home, some patients, they may do self-care hemodialysis in an outpatient in-center medical setting. So training for both, let's say, PD and home hemodialysis is going to begin at an in-center facility. Assisted dialysis on the right, however, whether it be hemodialysis or PD, is going to be performed by a trained caregiver and can either be in the home or medical setting, such as a skilled nursing facility. So the executive order of 2019 and CMS regulations of 2020, they promote home dialysis basically because it's going to open the way for home dialysis patients to receive more assistance with both PD and home hemodialysis, also known as HHD. Now, the next few slides are going to basically provide an overview of self-care, home dialysis options, and considerations. So, Bray wrote that self-care of dialysis is basically a modality which introduces the patient into a continuum of care ranging from dependency to independence. So, greater knowledge of the diacyclic process itself is going to be achieved. If this is, or let's say it's by means of when a patient can again achieve an active and meaningful lifestyle associated with a feeling of physical and emotional well-being. Her concept, as you can see, of self-care dialysis aligns with Oral's nursing theory, which basically focuses on helping patients become as independent as possible in their self-care. So her Oral asserted restoration to health and well-being is achieved more quickly when patients are allowed to care for themselves. To do self-care, a patient has to basically satisfy three requisites. So basically, we got universal, developmental, and health deviation. If these requisites are not met, a self-care deficit is going to occur. This basically is where nurses are this is where basically we shine. So nurses they're going to be determining the patient deficits and defining a support modality to meet them until the patient, say, is able to basically assume care on their own or for themselves. The patient also is going to have the point when the deficit is going to be no longer existing. And therefore, in doing so, patients are going to be empowered to care for themselves, knowing that they have a better, I say basically a partner in care, which is basically be us as being the nurse. Together, the nurse and the patient, they can explore the available self-care dialysis options. Also, many patients can also realize that the more suitable benefits of self-management as outlined in Curtis' definition by practicing self-care management. So self-care management of CKD going to require learning new skills, including changing behaviors, managing medical aspects, interpreting and reporting symptoms. Other skills that may be acquired are going to be learning to seek out and also use resources that are going to be effectively and forego a different, more collegial relationship with the healthcare provider regarding self-care management. So this slide here basically illustrates one of the tools developed by the Home Dialysis Central to assist patients in making an informed choice. So basically the goal here is to empower all patients to be central to their decision making and making informed decisions or choices. So this tool, for example, is going to help the patient understand what option works best for them to do what they want to do in their life. So the advantages of self-management or home dialysis are that patients can control their own treatment schedules, resulting in increased independence and those flexible lifestyles. Also, know that many patients find it easier to maintain employment status, especially if they begin kidney replacement therapy on peritoneal dialysis. So, self-care patients also report an increased sense of well-being and say they have basically more energy and can perform, let's say, regular daily activities such as work or school. They have a positive experience, going to be leading to an increased adherence to, let's say, the prescribed therapy. Also, because of the increased amount of dialysis that they do, patients' diets and their fluid intake tend to be, let's say, a little bit more liberal than some of the other treatment options. One of the greatest benefits, however, of self-care dialysis is going to be the case for regarding when it comes to travel. So much of the equipment is going to be portable. Also, supplies can be shipped as needed. In addition, we'll be having frequent dialysis, and self-care going to be decreasing morbidity and mortality. Also, going to be knowing that enhanced clinical outcomes, treatment done at the patient's convenience, and increased environmental safety, all at a decrease of provider expense, going to make self-care dialysis a win-win situation, a win-win option. So the most common self-care KRT is going to be peritoneal dialysis, unlike hemodialysis. So this basically is bloodless modality in dialysis, which is going to be basically clearing the blood directly. So PD training is going to be initiated in the center and ultimately transferred to the patient's home setting with competence and mastery, let's say, of this modality, with or without the assistance of a partner. So patients based on this modality are going to report greater independence, which is going to be closely associated, let's say, with a greater control of their schedule, freedom to travel, and positive outcomes. So these same benefits are going to be enjoyed by patients who choose home hemodialysis, once again known as HHD. So the initial teaching process for HHD is going to start, let's say, in center. As the patient, say, gains competence and mastery of the modality, the patient transfers to the home setting where they actually going to be performing treatment at home and done with the assistance, let's say, of a partner. So maturation of a AV access, cannulation training, and learning more complex machinery means that this option will require, let's say, considerably, let's say, planning, surgery, and training at the patient's comfort level. So both home therapies require the patient's home to have sufficient utilities and storage space basically to support and to basically house the equipment and supplies being used regarding these treatment options. Additionally, designated therapy area must be kept pet-free and clinically clean. In-center self-care is going to be an option for patients who are able and motivated to self-care, but have barriers, however, to home therapy. Medicare allows and encourages this option. Now, with in-center self-care hemodialysis, the patient is going to be performing most of all of the care or treatment process in an in-center setting. The nurses and the staff are going to be providing education, support, and guidance to the patients as he or she transitions from a total dependence to independence. In the following slides, I will be discussing the principles and preparation for each home option for patients with advanced CKD. However, Module 6 of this series is going to provide with you more details, including long-term utility of home kidney replacement therapy. So peritoneal dialysis is going to be a treatment for kidney failure that uses the peritoneal cavity. So during PD, the peritoneal cavity is going to hold 2.0 to 2.5 liters of sterile, use a glucose-containing dialysis fluid, which is going to be exchanged 4 to 5 times daily. So fluid exchange is going to be occurring through an indwelling catheter, which is going to be placed at least 2 weeks before the start of therapy. So the highly vascular peritoneal membrane is going to be acting as an endogenous dialyzing membrane. Now, across the membrane, going to have waste products to be diffusing to the dialysate, while excess body fluid is going to be removed by osmosis, induced by dialysis, fluids, glucose, or other osmotic agents. Now, PD is usually done daily, 7 days per week, then can be done 1 or 2 ways. It also is it's a slower process. There's also a less of an incidence of electrolyte imbalance, which can occur with hemodialysis. Dialysis is going to be infused by gravity. This is going to be termed, let's say, as known as field. Fluid is going to be staying, let's say, dwelling in the cavity for a specified time prescribed by the physician or care provider. Then the fluid then is going to flow or drain from the body by gravity into a drainage bag. So the most common type of PD is going to be your automated peritoneal dialysis, also called APD, or continuous cycling peritoneal dialysis, also called CCPD. So this method of peritoneal dialysis is going to use a machine called a cycler to do basically, let's say, those exchanges, each of which is going to be consistent of dialysate inflow, dwell, and outflow according to the preset times and the volumes, usually at night while the patient, let's say, is sleeping. Now, the cycle is going to be programmed to do, let's say, 3 to 5 overnight cycles, lasting from 1.5 hours to 2 hours, or sometimes even, let's say, 3 hours. Now, the patient, they then may have a single long daytime exchange lasting from 12 to 16 hours, or perform a single daytime exchange manually. Also, with this method of PD, the incidence of peritonitis is going to be reduced because basically here we have fewer connections and disconnections. So the original type of PD, which is less commonly used nowadays, is called our continuous ambulatory peritoneal dialysis, also called your CAPD. So in CAPD, the patient here will be manually performing 4 to 5 exchanges a day. Fresh dialysate is still going to be infused into the peritoneal cavity and allowed to dwell for 4 to 6 hours. After this period, however, the patient is going to attach a new empty bag and a fresh dialysate bag to the catheter using a connecting tube. So dialysate in the patient's peritoneal cavity can now drain based into the empty bag, and a fresh dialysis solution is being infused. Now, each exchange takes about 20 to 40 minutes. CAPD is going to allow constant removal of fluid and waste and more closely resembles the kidney's urinary function than hemodialysis. So, in summary, the benefit of peritoneal dialysis is that it's going to provide a slow, continuous physiological mode of waste and excess fluid. Removal is going to be gentler for the body than hemodialysis, as well as more suitable blood chemistry and hydration status. PD is a home-based therapy that most patients can do themselves. In addition, it's going to allow patients to have a better quality of life because of greater flexibility in treatment schedule and ease of patient travel. There's also some evidence, however, that PD patients may be a better candidate for kidney transplantation as compared to patients who are on hemodialysis. Yet the cost of PD treatments is lower than that of hemodialysis. So we have to make sure that is known. Also, we know that PD is significantly beneficial in the short term because it's going to not require a vascular access. Also, PD is usually the preferred dialysis modality in children because basically it's needle-free, it allows the child, let's say, to attend school, and it's going to reduce hospital visits. Lastly, residual kidney function is better preserved in PD patients than in patients who are undergoing hemodialysis. Okay, so also we know PD is best used for patients with residual kidney function, although anuric patients may also do well with this kidney replacement therapy. Most patients who start PD will eventually transfer to other modalities like KRT, such as hemodialysis, if adequacy cannot be maintained because of membrane failure or other complications such as recurrent peritonitis, extra site infections, or catheter problems. Now, peritonitis is going to be a major complication of peritoneal dialysis. The most common cause is going to be connection site contamination. Some common clinical manifestations of peritonitis are going to be cloudy effluent, elevated temp, abdominal pain, greater than 100,000 culture count, most often being staph epidermis or staph epi or staph aureus. Also, to prevent, let's say, peritonitis, the patient must also use meticulous sterile technique when caring for the PD catheter and when, let's say, hooking up or clamping off dialysate bags. Also, because achieving, let's say, adequate clearance regarding, let's say, large or heavy patients is complex, and because of the caloric load from, let's say, that glucose and PD solutions, this can result, let's say, in additional weight gain. Overweight and obese patients, however, have been discouraged from using this form of treatment. Also, we know that non-adherence is also a challenge when it comes to this form of kidney replacement therapy. PD is also a home-based therapy, and its success depends on patient compliance to prevent, let's say, inadequate clearance and complications such as peritonitis and excess site infection. So adherence is going to be one of the mainly considerations when it comes to advising patients on their suitability for peritoneal dialysis. So the inability to adhere to the strict requirements to prevent basically infection puts the patient at risk, let's say, regarding a life-threatening risk. The various limitations are going to be medical, and a medical assessment is going to be needed to inform the team about the patient's appropriateness for, let's say, PD by the individual patient. Some of the potential complications or contraindications to PD going to be included adhesions, surgically uncorrected abdominal hernia, or an abdominal wall stoma, a diaphragmatic fluid leak, recent abdominal aortic graft, large polycystic kidneys, ventricular peritoneal shunt, intolerance, let's say, of intra-abdominal fluid, large muscle mass or morbid obesity, severe malnutrition, skin infection, bowel disease, and carriage also of staph aureus. So the two main options, let's say, for self-care hemodialysis are home hemodialysis and in-center self-care hemodialysis. So home hemodialysis is going to allow the patient greater independence and flexibility. Home hemodialysis is also going to offer, let's say, many length and frequency choices. In contrast, though, in-center dialysis is usually offered 3 times per week for 3 to 4 hours per session. So patients, there are assigned specific, typically, those rigid treatment schedules, which along, let's say, the need for transportation to and from the center. These types of things here, it can be problematic, let's say, for some patients. And there can also be an additional downside when it comes to, let's say, that post-dialysis recovery time. Now, research basically has shown that patients stay on home hemodialysis have improved survival rates and quality of life compared to assisted in-center hemodialysis patients. So patients, let's say, who are also motivated are able to perform self-care, they have a willing partner and have a right home environment, they're going to be good candidates for home hemodialysis. So in-center self-care dialysis is going to be your modality in which the patient performs most or all of their treatment processes by themselves in an in-center setting. So the ultimate goal here is that the patient is to take control of their treatment process or possibly to transition to home hemodialysis And the nurses and staff in the center can provide, let's say, education, support, and guidance as the patient, let's say, becomes more independent. Now, this also is a Medicare approved option. So whether done at home or in center, the self-care hemodialysis process differs from assisted in-center dialysis only in terms of who the caregiver is. Hemodialysis is going to be frequently used to replace the function of the patient's kidney. It does this basically by removing waste products directly from the patient, say their blood. The picture above, as you can see, it shows the hemodialysis process. Now, the following slides going to give an overview of this remaining KRT option. So with hemodialysis, we have the process of diffusion, osmosis, and ultrafiltration is going to occur in the dialyzer. Diffusion basically selectively allows particles to pass through the semipermeable membrane of the hollow fiber dialyzer, depending on, let's say, pore size. Blood cells and proteins, however, they're going to be too big to pass through. But urea and creatinine move easily, let's say, from the blood to the dialysate for removal from the blood. Osmosis. It basically refers to the movement of fluid across the semipermeable membrane. Ultrafiltration is going to occur with negative pressure, and convection applies specifically to pull that extra fluid across the dialyzer membrane from the blood, which is then, let's say, returned to the patient via their vascular access. So as mentioned, vascular access is going to be critical to patient-centered care for the advanced CKD patient. So research suggests that basically early creation of an AV fistula going to offer the best protection against early morbidity and mortality for patients on on hemodialysis. An AV fistula is going to be your surgical connection of an artery and a vein in the arm to form a enlarged high flow vessel, basically your patient's vein. This is going to become the patient's life site, or the site, let's say, for needle access when it comes to dialysis. Also, AV fistula is going to be recommended for hemodialysis patients because it's going to use the patient's native artery and the patient's native vein. It involves, however, no foreign material. So nephrology nurses are also going to be very good at knowing when a fistula vein is ready for cannulation. So the KDIGO guidelines of 2006 published the rule of 6 to determine vein maturation. So there should be greater than 600 milliliters per minute having flowing through the vein. The vein should be greater than 6 millimeters in diameter. And to ensure successful cannulation, the upper surface of the vein should be less than 6 milliliters below the patient's skin surface. Now, an X-ray should thoroughly examine all fistulas no later than 6 weeks after placement to help ensure that the fistula's utility for dialysis. So not all patients, though, have blood vessels that are going to be suitable for a successful AV fistula creation, but all patients should be thoroughly assessed to make this determination. So once hemodialysis, let's say, begins, cannulation should practice consistent rotation of the needle sites and practice strict aseptic technique with all cannulation to basically prevent the formation of aneurysms in the vein and an infection. So if an AV fistula, let's say, is not possible, the next best choice is going to be an AV graft. An AV graft should be placed if the patient's veins are not large enough or healthy enough to be used for an AV fistula. A synthetic graft is basically the most common type. However, biological grafts, either bovine or cryopreserved human vessels, are sometimes, let's say, used. Infection and thrombus are going to be some of our things we're going to be seeing likely, let's say, regarding the complications, which is why, let's say, fistulas, let's say, are more preferred over a AV graft. Grafts may also be placed, let's say, in the patient's forearm, their upper arm, or the thigh. A graft need not be placed until the patient, let's say, is 2 to 4 weeks away from needing hemodialysis. So this is going to give, let's say, time for the graft to heal and post-op swelling in the patient's arm to subside. So the central venous catheter, also known as a CVC, is going to be the third option for vascular access. It should only be used temporarily while peripheral access, let's say, matures. Hemodialysis catheter is going to be a dual lumen tube, usually placed in a jugular vein with the tip in the right atrium. Now, during dialysis, blood is going to be continuously removed through one lumen and returned through the other at about 400 milliliters per minute. So a central venous catheter basically has a high risk of infection and malfunction, and therefore it should be avoided if possible. Infection is going to be our leading cause of hospitalization in patients undergoing hemodialysis and the second leading cause of death. So many patients choose instant hemodialysis because basically of the sense of safety and security that they get from, let's say, having that trained dialysis nurses and technicians administer their treatment, along with the availability of a doctor, especially, let's say, in those urban areas, and other personnel inside the center. Now, many patients also enjoy the support, let's say, from dialysis staff and other patients. Many patients dislike, however, the idea, though, of daily treatments and prefer to go to the dialysis center 3 times a week. However, there is a downside of that post-dialysis recovery time and the dietary and fluid restrictions imposed by this schedule. So whether or not a patient will have hemodialysis depends on the decision of the patient's family, and the interdisciplinary team, predominantly, let's say, the nephrologist. So some things to consider include the patient's age, comorbidities, and whether or not hemodialysis will improve, let's say, the patient's quality of life. It is also important to determine, let's say, if the patient can tolerate hemodialysis, whether the patient can make an informed choice, and whether the patient has any advanced care planning documents. So for patients, let's say, for whom transplant, PD, and hemodialysis are not options, there is another treatment option called supportive management and palliative care. So supportive management, it can use a combination of treatments such as medications, dietary, and fluid management. So KDIGO has formulated guidelines for comprehensive supportive management as an option for patients who choose not to pursue kidney replacement therapy. So these guidelines basically state that all CKD programs and care providers should be able to deliver advanced care planning to people or for people with recognized need for inner life care, including these people undergoing supportive management. So care, it should include protocol for symptom and pain management, psychological care, spiritual care, and culturally sensitive care for the dying patient and their family, whether it be at home, in a hospice facility, or in a hospital setting, followed by the provision of culturally appropriate bereavement support. So palliative care, it can provide quality of life, if not quantity. It can be offered at any point in the time of, let's say, of the patient's illness. So the goal of palliative care is basically to relieve suffering throughout a patient's illness, thus improving the quality of life for the patient and their family. It consists of team collaboration, providing, let's say, patient relief, let's say, from symptom, pain, stress, or let's say, of that serious illness, as well as transitional care. So the Renal Physician Association developed a clinical practice guideline for stopping or never beginning dialysis in certain patients. So this guideline basically rely upon shared decision-making, informed consent or refusal, estimating prognosis, and offering a time-limited trial of dialysis if indicated. So please see Module 8 for more detailed information regarding palliative and end-of-life care for patients with CKD. So the definition of CKD stage 5, according to KDIGO and National Kidney Foundation KDOKI guidelines is that kidney failure with a severely decreased estimated GFR of less than 15. So, what does that mean in terms, let's say, of patient-centered care? So, well, that means that regarding the time of initiation, let's say, of kidney replacement therapy will be based on the signs and symptoms of the patient. Okay, GDIGO also says that dialysis should be initiated when one or more of the following are present. So basically, signs or symptoms are going to be attributed to, let's say, the kidney failure, such as inflammation, acid base or electrolyte abnormalities, or pruritus, inability to control volume status or blood pressure, a progressive deterioration in nutritional status, refractory, let's say, to dietary interventions, or cognitive impairment. Hopefully, however, with early referral, the patient and family have the time and education to develop a plan of care with the nephrology team. A late referral, it may require an urgent start. So, meaning basic treatment here is going to be first, meaning treatment first and education later, with decision making about KRT options taking place after the initiation of kidney replacement therapy. So a planned start to hemodialysis is going to occur when the patient and family have made an informed decision about this modality, with the patient, let's say, having vascular access in place and treatment scheduled to start in an outpatient facility. If the modality choice is peritoneal dialysis, a planned start means that the patient has had a scheduled implantation of a peritoneal dialysis catheter for at least 2 weeks before the scheduled treatment. And training has started, let's say, or is scheduled to start at a PD facility. Now, the 2-week period is going to allow the patient basically tissues to heal around, let's say, the catheter, reducing the risk of, say, of infection to occur, and I'll say, let's say, from leaking once the PD exchanges begin. Conversely, though, however, urgent starts are typically patients who present at a doctor's office or an emergency room with severe uremia. So medical care is going to take precedence in assessing, diagnosing, hospitalizing, and treating the patient. A dialysis access is going to be placed, usually a central venous catheter, with hemodialysis initiation. Now, when stable, though, the urgently started patient is going to be discharged to an outpatient facility for kidney replacement therapy and education on future options. So education on future options is going to be pivotal to, let's say, patient-centered care, regardless of, say, other modalities used to start kidney replacement therapy. So this data here basically shows us that quality of life is best with a transplant, followed by the self-care dialysis options. Now, while a limiting factor of transplantation is going to be the availability of those donated kidneys, we also know that many more patients could benefit from self-care dialysis in both quality and quantity of life. Now, the executive order of 2019 and the CMS trial begun January 1st, 2021 are designed to increase transplantation and the number of patients doing home versus in-center assisted dialysis. Please also see modules 6 and 7 for more detail regarding this information. So in summary, whether planned or urgently begun, kidney replacement therapy initiation is stressful and life-changing, but life is the operative word here. So dialysis is going to allow patients with kidney failure to do what they want to do with the rest of their lives. Also, we know that many patients will experience more than one modality of kidney replacement therapy, and some will have the opportunity to regain kidney function with a transplant. It is also beyond the scope of this presentation to detail the psychological and the psychosocial consideration that patients may face in this new life, but they are not alone. Not only say do patients have 24/7 access to their interdisciplinary team, They also have that assurance that their care is under the supervision of Medicare, and it consists of 18 ESRD networks. Now, for patients, say under 65 years of age, kidney failure is going to be the only disease state that qualifies the patient for Medicare disability coverage. Patients also with private health insurance, they must remain their primary coverage for 30 months with Medicare secondary until that point. Home dialysis is going to qualify this patient from day one, but assisted hemodialysis has a 90-day waiting period to qualify. Transplanted patients will receive Medicare coverage for 36 months post-transplant, and donor costs are also covered. Now, some government agencies and many CKD patient support organizations also provide education materials and social support. Those and other resources are listed in the PDF handout for this module. Now, for more information on chronic kidney disease, kidney replacement therapies in both adults and children, please see other modules on the ANNA website. So thank you for the care you give our patients who have CKD and for choosing to learn more about them and their therapies through these modules. You can download from the online library a PDF copy of these slides, the printed narrative, as well as a list of references and resources that are used in this presentation, and link to the glossary of terms. You can also see here regarding the acknowledgement, let's say, of the authors and reviewers in the CKD modules presented. Definitely like to thank Leslie Dinwiddie regarding, getting these modules together and for us to present these modules. So thank you once again, Leslie. Here are the references provided. And for more information about CKD care and the ANNA, please visit our website and our online library. Thank you so much for this presentation. Have a great day.